So let me start by saying, the previous two speakers have emphasized the governance issues, and those are clearly extremely important. My concern is that we shouldn't allow that concern to stop us having the discussion about what is the problem that we're trying to solve. So let me step back for a second and introduce who I am. I'm actually a rheumatologist, believe it or not. I'm a physician, and I worked in the Gauteng Health Department actually before Alex, between 96 and 98. I worked briefly in the National Treasury, and then I worked at Discovery for about 16 years. So I'm very well versed with contracting. About 4.5 years ago, I left because those guys were really losing the plot. But I left in particular because I recognized that we needed to start creating different models of healthcare delivery. And so while not for a second in any way trying to deny the importance of the governance issues that the previous two speakers have spoken to, I do want us to also start thinking about how do we address our production problem. And I think, Alex, you said it well. We have a production problem in both the public sector. We have very low productivity. We have poor service, poor outcomes. We have a management problem that results in us using the very large resources that are available in the public sector. We use them quite poorly. In the private sector, we obviously have a different kind of production problem, and that's a problem of over-servicing. The private sector has something like a third of all the private beds, maybe 70% of all the specialists, half of all the MOs or GPs in the country, but only 15 or 16% of the population. In order to survive, there's an enormous amount of over-servicing, of waste, and frankly, that system is extremely destructive of the public sector. It's not, I often hear people saying, before you do NHI, go and fix the public sector. You can't fix the public sector without the assets that the private sector represents. And so the real question for me becomes, what's your diagnosis? And I'm going to say my diagnosis is two things that are common to this low productivity that we have in both systems. The first one is, at a technical level, do we understand the widget, the patient that's going through the system? And any country that I've ever looked at who has a successful health system has a lot of health information, in particular case mix information about who are the patients on the demand side and where are they being managed. And when you understand that, you understand all the time your outcomes and your productivity. If you don't understand your outcomes and your productivity relative to your case mix, you will not be surprised when your system doesn't change. If there's no information, if there are no messages about your productivity, why would it change? And I think that's perfectly true. Alex mentioned this very slow decline. I think the slow decline is equally true in the private sector. These systems we've been working in these systems for 20, 30 years. It's remarkable how little changes. And I'm saying that there's so much stasis and so little changes because we don't have a diagnosis of what's wrong. So problem one is we have no information about the productivity, about the outcomes, and therefore there's no reason to change. Number two is we don't have an economic model that works. And I've described that already, these two different fundamentally flawed models. And so the international consensus on which the NHI is in fact based is that the correct approach is strategic purchasing. Essentially a purchaser versus provider split in which a competent purchaser with the kind of information I'm talking about enters into contracts and purchases access of a certain quality and of a certain productivity from the supply side, regardless of whether that supply side is a commercial system, a not-for-profit system, or a state-owned system. That separation is the consensus model, the WHO recommended model, in fact, around the world. And so the real question for us becomes, how do we create a model that leads to convergence? How do we create, we can't wave a magic wand and the money and the specialists and the beds of the private sector are just magically all available to the public sector. What we require is a different delivery model. And that delivery model has three characteristics. It has to be able to look after high volumes of patients. It has to do so at low cost, and it has to produce good quality. Now, that doesn't describe the model of delivery that we have in either the public sector, in particular, it doesn't describe the model that we have in the private sector. And so the real question is, the Medical Schemes Act is in fact based on a purchaser-provider split. And so the real question is, why did it fail? Alex talked about the market failure, and I completely agree with him. It failed essentially because of a lack of regulatory oversight. But there was, in the face of that regulatory oversight, what is remarkable is that the large, competent purchasers, including the one that I worked at for a long time, made a very deliberate decision to not play their role. They made a decision to carry on with fee-for-service, with individual doctors. They made a decision not to commission team-based care that could deliver the kind of high volume, low cost, high quality. They made that decision because, and I think the HMI provisional report and the one that's coming out next Monday, I'm sure will reinforce that, because at the end of the day, they wanted the model, the status quo to carry on. And so there must be consequences. We can't think about the medical scheme administrators as playing a competent role in this new NHI when they made a deliberate decision to not, in the face, it must be said, of absent regulators, of a regulator that didn't understand what its mandate was. They still made a decision to carry on with this failed system and to allow this stasis to carry on. And in many ways, that's why I left Discovery. And in many ways, what I see happening is what we're trying to do at PPO-Serve. PPO-Serve, we deliberately got together, we created a methodology that did exactly that. It says we don't want doctors, we especially don't want specialists, to be working on their own. We don't want specialists to be working in competition with primary healthcare GPs, with primary healthcare allied health professionals. We don't want the orthopedic surgeon to be working as many do in the private sector, or the obstetrician, looking after 12, maybe 13 patients a month. That's the reality. That's the average. We want those people to be in charge of large teams, leveraging their knowledge for thousands of people, not for a handful of people, because it's possible to make a lot of money working for, in this very high-cost, low-volume model. And I think that what we are much more likely to see is a model, an NHI model, that is quite incremental. And so I think what we're likely to see is that there will be, in provinces at a primary care level, there will be units, and I think you're talking about this already, MEC. You're talking about saying, and there has been a couple of NHI tenders in which government says, is there a commercial, is there a private sector delivery service who can respond to these kind of requirements, namely to deliver this kind of volume of service at this kind of price? And the reality is, I think outside of ourselves and maybe one other small company, the private sector simply is not organized in that way. And the result of that is, until that if the public sector wants to talk to the private sector about a model on which we can start developing a highly productive system, the starting point has to be, what does that model look like, and how do we do the strategic purchasing in order to support those kind of models? And just to respond to you, MEC, I don't think it means contracting in. Taking private doctors into a badly managed public sector doesn't seem to me to be the right system. On the other hand, I do entirely agree with your understanding that healthcare delivery is local. And so this question of these contracting units for primary care is very important. And I don't see that that has to be done in an ideological way. It doesn't matter if the management team is private or not-for-profit or in fact public sector management. What does matter is that the work that is done, the work that is commissioned, the work that is organized for that local population is done in such a way that it's high quality work for many people at low cost. That becomes, for me, the most important point. And so just the final point is we talked about the scare tactics around specialists and think maybe it comes out of what I'm saying. Nobody's threatening the income of private doctors. What I think the model is threatening, it's saying you cannot earn the kind of money that you do and do so little. You must be a specialist consultant. You must run a team. We need to leverage your scarce skills. You can't sit in your office and earn 300,000 or 400,000 rand a month being involved in 10 or 15 cases. It just doesn't work. Thank you.